Hello again, everybody, and welcome to Doc Talk with Monument Health. I am Mark Houston, and joining me again is Dr. Christopher Gasbarre, dermatologist from Monument Health in Spearfish. Welcome back, Doctor. I appreciate you taking some time to come all the way over.
No problem. Thanks for having me.
to the big city. Last time we talked to you, we kind of covered the basics of just skin and skin cancer in general and things you need to look out for. And if you ever end up in a situation where you may have skin cancer, there is a procedure that can be done that you specialize in. You actually have a fellowship in this procedure. So I want to talk about that on this podcast specifically. It's called a Mohs procedure, correct?
Yeah. Correct.
All right. Well, give me the details on how this works, doctor.
Sure. So Mohs micrographic surgery was developed by a guy named Fred Mohs, who was a surgeon. He first wrote about the procedure, or some semblance of the procedure, in the late 1940s, early 1950s. It's been developed since then and has changed and evolved over time. What we do today probably came into being in the late 70s, early 80s, and has evolved from there. What we do is, and where the magic of Mohs surgery comes in, is we remove a piece of skin, which is presumably what we know to be cancer, with a very narrow margin around it. And we process it in our own lab just down the hall from where you're having surgery done, where we can look at what we call the circumferential margin. So if you think of it as kind of like taking the outside ring of an onion off and lying it flat, looking at that outside edge. So if the piece of tissue we're removing is, think of it as half an onion, we're taking that outside ring or two off, lying it flat on sides and looking at it under the microscope. Traditionally, what a pathologist will do when you send them a biopsy is we're asking the pathologist, what is this? We're sending it into them. Well, they'll take the piece and they cut it like a loaf of bread. If you want to know what type of bread a loaf is, you generally want to cut it 90 degrees and lay it on its side and say, oh, it's rye, right? Well, we already know what it is because we've already had that, got that information back from the pathologist. So what we're doing with Mohs surgery is we want to know, are the crusts clear? Skin cancers don't jump around. They start in one spot and grow circumferentially, so they grow outward. And because they don't form a lot of skip areas, if the outside edge, including the lateral edge and the deep edge, so the side and the deep margins are clear, then we know we got around it. And so that's what we care about. We don't care what's in the middle of the piece we took. So we're taking that outside edge off. So if you can visualize an onion, that's probably the best way to think of it. Also think about it as a three-dimensional structure that we're lying flat, kind of like half of a globe. We're taking that curvature and lying it flat. And then we ink the margins and have orientation so that we're essentially making a map as we go. So if we see skin cancer at an edge, we know exactly where it is in relationship to your body to go take another piece if we need to. But we don't have to take a really large margin around it to, quote, make sure we got it all.
Is that how it used to be?
So, and we still do that for some things.
Sure.
And that's called a wide local excision, where you take what's deemed to be, through study, we do research on this, what's the acceptable margin to get a good clearance rate, and you take that margin. Well, with certain types of skin cancers and Mohs surgery, we don't have to take those large margins. We only have to take a millimeter or two margin around it to start with and make sure that we get it clear. And so Mohs surgery does a couple of things. It gives us our highest cure rate. So our cure rate with Mohs surgery is 98 to 99%, depending on what study you read. And the cure rate means what's the likelihood it's going to grow back in 5 years. So that's about a 1 or 2 in 100 chance that it's going to grow back again in 5 years, which is the best cure rate we have of any treatment we have for skin cancer. And it also saves as much normal skin as possible. And so if this skin cancer is in the middle of your nose, a couple millimeters of skin makes a big difference on how I repair it later.
Yeah.
So that can be pretty dramatic in terms of reconstruction options later.
Right, and that's I think one of the big questions that people would be worried about with this is the scarring, especially in those cosmetically sensitive areas, right? And this really kind of limits that then.
If we're going to do surgery, we're by definition going to create a scar. This would be the best way to minimize that on cosmetically sensitive areas. And because of that, we save Mohs surgery for certain areas. It's not indicated for certain locations. For example, for if you had a really small skin cancer in the middle of your back, we wouldn't do Mohs on that. We would do a wide local excision or some other method. There are a lot of different ways to treat skin cancer, and some of them are very appropriate for different types of skin cancer.
So is Mohs specifically, well, not specifically, but is it best suited for areas that you don't want large amounts of scarring then? Would that be fair to say?
Areas where either we don't want large amounts of scarring, areas where it's going to be very cosmetically or functionally sensitive to repair,
okay.
or we run the risk of a high recurrence rate. So there are certain areas on the body where skin cancers have a higher rate of growing back again. And
what areas would those be?
So there are a couple. One is what we call the H zone area of the face. So on the head and neck, areas around the eyes, nose, mouth, ears, and temples.
Really? So much on your head. Oh, I just want to touch my face now because of that. But
and then other high-risk areas are hands, feet, and genitals.
Okay.
So a lot of folks figure, well, I'm never going to get a skin cancer where the sun doesn't shine. But you can, because sun isn't the only risk factor for skin cancers. We see, for example, squamous cell carcinomas from human papillomavirus, particularly on genital skin. And so that can be a risk factor for those. So we will occasionally do Mohs surgery in those locations as well.
Now that's the HPV, correct? And that's technically there's a vaccine for that now, sort of, isn't there?
There is.
So have you seen a drop in that then because of the vaccine for it, or is it still about average?
That I don't know nationally whether we've really seen that yet. So it has had an impact. It's probably a little too early to know. Presumably, we will see a decrease in that. Now, the vaccine blocks the 4 subtypes of HPV that are most commonly associated with cervical cancer. That may not pan out completely with skin cancers. So the areas where we'll see HPV association with skin cancers are largely genitals and sometimes hands, fingers, because we'll see skin cancers around the nails on occasion as well, and have to do Mohs surgery on the nail because skin cancers will pop up under the nail.
So the most common face, that's what was going to answer my question. The most common place is your face generally for skin cancers?
For non-melanoma skin cancers, absolutely. The head and neck are the most common, and on the head and neck, the nose is the most common spot.
Oh, boy. How many people are involved in this type of procedure? You, obviously. Do you have a team in there with you?
Sure.
How does it work when somebody goes in?
Yeah, sure. It's always a team effort.
And
I have a great team with me all the time. We have nurses and medical assistants that work with us. We also have a histotech who will actually process the tissue. So
okay, what is that? What's the histo?
So
I haven't heard this term before.
Yeah. So this is the person who actually takes the piece of tissue, and remember we talked about the onion analogy earlier. It's the person who's taken the half of the onion and actually processing it and putting it on the slide so that I can look at it under the microscope. It's an art form, it's a highly skilled procedure, and the folks are really good at it. But basically, what you're doing is taking that piece of tissue and you freeze it in a block of, essentially it's sugar molecule. It's a gel. So you embed it in a gel, freeze it like a block of ice, and then you, at low temperature, so it stays frozen, you actually plane off very small sections, just like you would when they take a biopsy and embed it in wax. But because we need it in real time, we need it quickly, so we can repair the defect on our patient. We have to have that back quickly. So usually within about a half hour, 45 minutes, they can process that tissue by frozen section method. And the other kind of art of Mohs surgery is that processing we talked about earlier. We're taking off that outside edge. So getting the tissue mounted so that you can actually get that 100% of that outside edge, and then I can look at that under the microscope. So the Mohs training is kind of comprehensive. It's the surgery, it's the removal of the tissue, it's how to process the tissue in the lab, it's looking at it under the microscope and being able to identify different tumors under the microscope and determine whether or not we're clear or not, and then also being able to repair the defect or the hole that we made after the fact. So
how deep does it usually go?
So usually most Mohs defects are just to the layer of fat right under the skin. We're taking out the full thickness of the skin.
That's still pretty, that's a chunk.
Depends where you are.
Sure,
yeah, it depends where you are
okay.
on the body. So skin thickness varies pretty dramatically on the body. But certainly we take care of skin cancers on occasion that have been there for quite some time or are pretty aggressive, and they can go down into deeper structures. I've seen skin cancers get down into the surface of the bone.
Oh, boy.
I've even seen skin cancers track down nerves into the skull. And so those are rare, thankfully.
Yeah.
But it is why we do Mohs surgery, because the longer a tumor is allowed to stay in place, especially on the head and neck, the more damage it can potentially do.
So if somebody has a procedure like this, what can people expect recovery time on something like this?
Sure.
What happens after it's done?
Sure. So for most procedures, if we're closing the skin with stitches or repairing it with a flap or a skin graft, stitches will be removed in about a week if it's on the head and neck. And so they will have an incision that is fairly noticeable in terms of a wound for about 6 weeks. And at about 6 weeks, the skin starts to kind of remodel that scar tissue. In the first 6 weeks, it's just basically trying to throw down as much glue as it can to hold that together. And then the body starts to remodel that tissue to make it look as much like normal skin as possible. So that's at about the 6-week mark, a lot of that inflammation and things start to settle down. And then the remodeling process takes up to about a year. But for the most part, things are looking a lot better at about the 3, 4, 5 week range.
Okay. What's the biggest one you've ever had to remove?
Probably, if it depends on how you.
How big can they get? Maybe that's my question. Can skin cancers get
quite large?
Can they?
So quite large and quite deep. Like I said, I've had skin cancers that have tracked down into the salivary glands, for example, in your cheek. I've had skin cancers that have tracked from the eyelid back behind the eye, where we've had to unfortunately sacrifice an eye. I've seen them destroy noses. I've seen them get erode actually through bone on the skull, and thankfully that's extremely rare.
Right.
But I have seen that happen. So I think that's probably one of the misconceptions about skin cancer, is that they don't do much harm. And thankfully, for a lot of them, that's true. We catch them early. They're small. We remove them with a high cure rate, with really very little in the way of scarring or deficit afterwards. Yeah. But left untreated, or if they regrow in a sensitive spot, they can do a lot of harm.
That I don't think a lot of people consider when they're like, no, I can be out in the sun for an hour and a half without a shirt on, right? You don't think about what can happen there. Boy, that can really drive it home for sure.
And they can spread. So squamous cell carcinomas can go to lymph nodes and spread in the body. We talk about melanomas doing that a lot, but squamous cell carcinomas can. Their risk of spread is probably only about 5%, but when it happens, they can be quite aggressive as well.
So Mohs is, like you said, been around about 70 years, give or take. Half a decade or so in there, and it's successful, and you guys have gotten better and better and better at it. What's next? Is there something in the pipeline that's as exciting that you guys are kind of looking forward to?
So where Mohs is
lasers is where I'm going here,
lasers?
Doctor. Yes.
Oh boy. We currently, where Mohs has gone and advanced probably most recently there's a procedure called immunostaining, where you actually can take the tissue that we remove from the patient and you actually use antibodies towards certain molecules to stain those cells to look at their expression and more easily detect things like melanoma cells. Traditionally, melanomas were not something we treated with Mohs surgery because they're very hard to read on frozen sections. With immunostaining, that becomes much more reliable. And so we've seen that with certain types of melanomas, Mohs surgery has been used with a lot of success, particularly, again, on sensitive areas where traditionally with melanomas, we'll take a very large margin around them to clear them. with Mohs surgery on certain types of melanomas, we can minimize that. That's a very specific procedure. That's come out probably in the last 10 to 20 years in some way, shape, or form. But the data on it is much better now than it has been, and it's a fairly limited procedure. Usually, that's done in larger centers because you have to have a lab that does immunostaining. For example, I don't do that currently, but it is an option for folks for certain types of skin cancers as well. I think in the future, I mean, ideally, and we talked about this a little bit on the earlier on our earlier discussion. I'd love to see a day where Mohs surgery is obsolete. Frankly, I mean, I love what I do, but really, what we're in the business of doing is treating skin cancer. And if we can develop a method that has the same cure rate as Mohs surgery, but doesn't involve a scalpel, that would be our ideal. Yeah. So hopefully we see that, and there are a lot of folks looking at different methods to do things like that. One of the beauties of working with the skin is it's accessible. Unlike a lung, I can get to most spots on the skin pretty easily. So we have access, and therefore we can deliver medications, we can deliver therapeutics to the skin much easier than folks in other disciplines can.
Speaking of the skin being so easy to spot, do you ever walk up to strangers and be like, I really think you should call a dermatologist. There's something there that's bothering me. Have you ever done that?
Thankfully, I have not had to do that with anybody I didn't already know.
Sure, okay.
But I have. I've had nurses that have worked with me in the past that have run into folks out in public, and you have to be very diplomatic.
Well, you do, of course.
You
Yeah.
don't want to seem real odd.
But as a doctor and somebody that wants to help, it's ingrained in you to be like, I really want to tell this guy or this woman, hey.
Yeah, I think done the right way, you absolutely have an obligation to do that. I think you look at it from an ethical perspective.
Right.
Would I feel real comfortable walking away from something that I know could be a problem? So I think you err on the side of caution.
Well, it's great because like most gastroenterologists can't go just walk up to somebody and see that kind of thing, where that's like a superpower for you sort of as a dermatologist. Absolutely.
Right.
Dr. Christopher Gasbarre, thank you very much. He's a dermatologist at Monument Health at Spearfish. Thanks again for coming in. Anytime you want to talk skin, we'll do it. All right?
My pleasure. Thanks for having me.
You bet. Thank you.